Okay, welcome in. We're going to discuss Chapter 6, Resistance Exercise for Impaired Muscle Performance. So some of our objectives today are going to be to describe the role of the PTA in data collection, management of the orthopedic condition, list and describe components of physical function. We'll talk a little bit about muscle length and related terms, identify characteristics of muscle mass, identify appropriate guidelines for determining the intensity, duration, and frequency of an exercise program. That's going to be a lot of where we spend our time today, as well as this next one here, explaining principles of muscular performance, including strength, power, and endurance. We're going to look at some of the principles of resistance exercise, associated types of equipment used in resistance training, and demonstrate competency in implementing those different types of resistance movements. So of course, there are plenty of benefits for resistance training and exercise, and this should come as no surprise to you on this list here. So we're going to, for our patients, look at enhancing muscle performance. So again, thinking of strength, power, and endurance. Resistance training also does a great job of increasing the strength of connective tissues. So whether it's used for prehab, rehab post-op, whatever, we're going to definitely see a large jump in the strength of those connective tissues. It's also great for our patients that have decreased bone mineral density, so something like osteopenia or osteoporosis. Just performing loading to the muscles will definitely benefit the bones and everything along those lines. So we're going to really increase bone mineral density with axial loading and just loading of the tissues in general. We can also decrease joint stress during activity by strengthening surrounding muscles of joints that are affected. We can reduce risk of soft tissue injury, and I always say reduce risk instead of prevent injury, because obviously we can't prevent injury. They happen regardless of how much effort and time you put in, but we can definitely reduce the risk of those injuries. It also helps to improve the capacity for repair and healing. So going into a surgery, if you're healthier, you're going to have a better prognosis following that surgery. We can also help to improve balance by challenging proprioceptors and different types of somatosensory areas of the body. Obviously enhance physical performance, a positive change in body composition, so decreasing adipose tissue while increasing lean muscle mass. And the two things that are at the bottom there are sometimes forgotten about, especially in physical therapy, but enhanced feeling of physical well-being and a positive perception of disability and quality of life. So let's get into muscle performance and look at these key elements here. So the ones that we're going to be discussing again include strength, endurance, and power. Let's learn about these a little bit. So here's the definition of strength: the greatest measurable force that is exerted by a muscle or muscle group to overcome resistance during a single maximum effort. So basically we're able to raise on the concentric version and lower eccentrically, controlling these heavy external loads when we improve our strength. And for our purposes, we're going to kind of use some pretty basic parameters surrounding strength. So around 3 sets of 10 repetitions with a moderate load or intensity. And if you are a gym goer and you're really in the gym often, you would typically use about 70 to 80% of your max 1 rep for strength purposes. So again, moderate volume, 3 sets of 10, that gives us 30 repetitions total with a moderate load, okay? So then we look at power. So what is power? So the definition of power is strength and speed of the movement, or we're thinking of this equation, work times distance. So basically what we're saying is we're trying to decrease the time in which somebody performs a movement. That's going to increase power, or we can just increase the intensity, increase that distance. And we have what we call anaerobic power versus aerobic power. So let's look at these two here. How do they differ? We're going to talk about more of these energy systems in our next chapter, but let's just kind of go over the basics here. So when we're thinking of anaerobic power, this is something that does not require oxygen to produce ATP, versus aerobic power, where we do require oxygen to produce ATP. And again, we're going to go over those different systems in our next lecture, in our next chapter. So how do they really differ? What does it look like? Maybe can we give an example of aerobic and anaerobic power? Well, think about anaerobic power as like your 100-meter sprint. Okay, it's lasting longer than 30 seconds, but we're still using a lot of power there, right? We're trying to move as fast as we can. That's part of that power component. And it's over a short period of time. Aerobic power, you could think about it as maybe somebody like a soccer player, where they're running miles and miles and miles every single match. But guess what? They still have to produce lots of power, short-term sprints, kick the ball. That would be more considered your aerobic power. So it's a longer period of time. Again, we're increasing that distance some, and we are still utilizing some of those explosive movements when they go to kick the ball or when they jump in the air and head the ball into the goal. That would be kind of more of your aerobic power. And again, just remember these parameters for power. It depends on the goal. Is it anaerobic power or aerobic power that we're looking at? But ways that we can manipulate the parameters is increase the load or decrease the time. Okay, we're thinking these are really high intensity activities. So, and what I mean by decreasing time is just think about, a regular, kind of like a box squat, right? You go to sit on a box and you return to your standing position. Typically, you're going to do that pretty slow. But if you're training for jumping, basketball or something along those lines, you're going to decrease the time in which you do basically a sit to stand squat, a box squat. You're going to do it pretty quick because you're trying to train for that anaerobic power. And then we come into endurance training here. So this would be something that requires lots and lots of repetitions over a prolonged period of time. So the goal is to resist fatigue. And our parameters here would be pretty high number of repetitions. So we're thinking volume is going to increase, but we're going to decrease the intensity so that we don't strain our muscles, become too fatigued. We're not trying to improve our power necessarily. We're not trying to improve our strength necessarily, but we're trying to resist fatigue. So endurance training would be great for somebody who can't walk through Costco for long periods of time. They have to sit every 5 minutes. Well, we can get them on an endurance program and really up the repetitions with that low intensity so that they can manage that activity better away from the clinical setting. And this brings us to our first principle for strength training. So we call this the overload principle. So basically what this says is to improve muscle performance, a resistance load that exceeds the metabolic capacity of the muscle must be applied. So again, we're thinking of intensity and volume here. So if you're strength training, we're doing 3 sets of 10, we're starting out there. We have a moderate load. We have moderate amounts of intensity, volume, all that kind of stuff. So in order to overload your muscle, let's say you've been doing that same program for 8 weeks, we need to increase the intensity. So maybe we can increase the weight. We have to overload in order to get better or to have any of these metabolic adaptations. And of course, we can increase the volume. So we need to overload the muscle in order to get better, reach those goals that we're trying to set for our patients. So again, how do we apply this in the clinical setting? Well, taking somebody post-op, let's just take that for instance. They come in with a rotator cuff repair. They are unable to perform active range of motion for about 8 weeks. And now they're out of their sling. They can do active range of motion. They've had a lot of atrophy in those 8 weeks, being, immobilized for the most part. So what do? Well, maybe overloading the muscle is just active range of motion, right? Because they've been immobilized for a long period of time. Maybe that active range of motion is going to overload the deltoid. Maybe it's going to overload the rotator cuff that was just repaired. And then as we progress from week 8 to week 12, week 16, then we're going to slowly increase the intensity, add resistance, add more volume to their program. We can't just do active range of motion for 16 weeks and expect the patient to be stronger. And then there's another principle that we have to talk about here. So the specific adaptation to imposed demands, or the SAID principle, kind of has these two subheadings here. And the one that I really want to focus on is the specificity of training. So what does specificity of training mean? It means that we just have to be very specific in the way that we structure our programs for our patients. So if their goal is to reach above their head, to reach whatever, brush their hair, reach up into high places in their closet to get whatever off the shelves, then we have to really be specific about what we're doing in our program. We have to do overhead training. Okay, we have to do overhead reaching, strengthening, endurance training. We have to do all those things. If that was their goal, is to reach overhead, and I'm just doing strictly external rotation the entire time, that's great. It's going to strengthen the rotator cuff. Maybe it'll decrease the amount of humeral elevation that you see with overhead reaching, but they still are going to be weak in that overhead reaching. So we need to incorporate those types of movements into their program. Just like an athlete who's returning to a sport needs to be very specific in their training to get back to high-level performance. Okay, so an example, post ACL reconstruction, we know the end goal is to get them back to playing basketball. They're going to be jumping, they're going to be changing directions, they're going to be very explosive in their movements. So as we near the minimum protection phase, or the very last phase of their training, we need to start doing those kinds of movements and activities before we send them back onto the court, the field, whatever it is. So we have to be very specific in our training. And the other thing on this slide is what we call the transfer of training. And basically what this states is there is some carryover of training from one variation of exercise to another. So let's just take strength training, for example. If we are utilizing strength training in a clinical setting, we're probably also going to increase some endurance for our patients. Okay, we're overloading the muscle, we're adding more volume, we're doing all those things. So we're going to improve strength, and there is going to be some overlap. We're going to improve endurance as well. But there are limitations for transfer of training as well. So if I'm working purely endurance-based exercise, let's say I'm riding a bike for 30 minutes to improve cardiovascular fitness, that's not going to help me perform explosive movements. It's not going to help me with my strength training. So there is a little bit of transfer of training, but more so whenever we're thinking strength to endurance, and not really endurance to strength or endurance to power. So again, that's why specificity of training is very important. And I gave you some examples already. And again, just to kind of emphasize this point of specificity of training, on the very far left-hand side here, we see powerlifter, right? They're doing a strongman competition. In order to get better at this movement, guess what you're going to have to do? You're going to have to lift some really heavy objects and place them up on top of this pedestal here. There's no way that you can get better at that doing a step up. And there's no way you can get better at that performing a high jump, okay? And vice versa. The person who's performing high jump isn't going to benefit from this type of training, okay? We have to be very specific in the way that we structure our programs. There's also what we call the reversibility principle. So basically what this is saying is that adaptive changes are temporary if not used for functional activities, or if the patient doesn't participate in a maintenance program. And this is really important because a lot of your patients, when they get their HEP, are going to ask you, how long do I have to do this for? Okay, and your response should be something along the lines as, well, you may not have to do these specific exercises for the rest of your life, but you should really try to incorporate exercise, fitness for the remainder of your time here, okay? So really important that we educate our patients on exercise and that we promote fitness, promote well-being, because if they spend 8 weeks with us and that's all they do, remember, well, those gains are going to be temporary unless they use it for functional movements and activities. And then there's also this last little component here called detraining. This is where we see a reduction in muscle performance. That begins typically within a week or two after cessation of resistance exercise. So it really goes back to this reversibility principle here, basically saying if you don't use it, you're going to lose it. Okay. The other thing that comes with this detraining is that if you're a well-conditioned athlete, if you're just well-conditioned individual overall, you can kind of minimize how much you're losing after 1 or 2 weeks, but still your muscle performance does struggle and begin to see a decline in your performance after that week or two of no training. Okay, so now let's look at this next slide here. Factors that influence muscle tension generation in the normal skeletal muscle. So the first thing that we have to consider are these different muscle fiber types. Okay, so we have these type 1 fibers, type 2A fibers, and type 2X fibers. Now, there's a random orientation, everybody's a little bit different, of all these different types of muscle fibers. So let's just talk about what these fibers are meant to do. So type 1 muscle fibers, we think of these as being slow twitch muscle fibers, okay? So there are postural muscles. So back extensors, we have a lot in our legs. Anything that resists gravity, pretty much anytime you're standing or sitting, would be considered a type 1 slow twitch muscle fiber. They are really, really good at resisting fatigue, meaning that they can contract over a long period of time without getting tired. Okay, so we're going to talk about the different energy systems again and try to relate them to type 1 and type 2 fibers in the next chapter, but let's just keep going with these different muscle fiber types. So type 2A is kind of this intermediate fiber. So it has characteristics of both type 1 and type 2. So it's considered to be a fast twitch muscle fiber. All type 2 muscle fibers are, but the type 2A is more resistant to fatigue than, let's say, these type X fibers. Okay, so type 2A has both characteristics, type 1, type 2, slow twitch and fast twitch, or really just resisting fatigue is the one that we're looking at here, but still able to perform some type of explosive movement, much so greater than the type 1. And type 2X, I just think of explosive, okay, explosive. So these are the muscle fibers that are really responsible for generating lots of power, but they are going to fatigue very quickly. So whenever you're walking through strength, power, endurance, I mean, these are kind of the things that we're looking at, right? What muscle fibers are we really targeting with our exercise? Are we doing endurance, where we're really stressing these type 1 muscle fibers? Are we doing a little bit of both? We're doing some endurance. We're having some of that carryover that we talked about earlier with some strength training, explosive training, and we're gaining some endurance. Or are we just working on strictly power, like that power lifter who was lifting all those heavy weights? And I would kind of suggest that they're kind of working both of these systems here, okay? Anaerobic power. Something else that we have to really consider too is a length-tension relationship. So we talked about passive insufficiency and active insufficiency earlier on in some of our chapters, and that's really what this is referring to here. So remember, with active insufficiency, if the muscle shortens at both ends, let's just say a 2-joint muscle to be really, to start easy here. Let's say we're doing leg extensions, okay, we're working quadriceps. If the muscle is shortened at the knee and it's shortened at the hip, well, there's not really a good length-tension relationship there. Okay, the muscle is too short to really produce much tension. Okay, so in order to really improve the length-tension relationship, we have to shorten one end of the muscle. So let's say at the knee, because we're doing the extensions, but we also want to provide length on, let's say, the proximal end of that muscle. That'll give you a better length-tension relationship. Okay, so we don't want to put the muscle in the most shortened position because that's where it's weak and that's where our patients are really going to struggle. Now, do we get into those positions sometimes in daily life? Maybe, yes, we do. And we can work towards being stronger in some of those end range positions. But for the most part, we want to give our patients the benefit of a doubt and really provide this good length tension relationship so that they can be strong and build strength and produce lots of power. The last thing on this slide, we're thinking of different muscle contraction types. So this is the force output from the most significant to the least in this order here, okay? So when we think of eccentric training, this means that the muscle is lengthening under a load, okay? And that's the important part, it's under a load, okay? So there's a lot of people that go to the gyms and they work on negatives. That's a negative sign, and I circled it. And basically what they're doing here is they're overloading the muscle, right? Overload principle. And instead of trying to lift the weight, they're just trying to lower it, control. That's because we are much more able to lift, or I'm sorry, not even lift, but lower heavy loads than we are lifting heavy loads. So maybe you put 405 pounds on the bench press and somebody picks it up for you, and then you just lower it to your chest nice and slow. That's producing a lot of force output, okay, more so than isometric or concentric. But then we get down to isometric contractions, and this is number 2 on the list, okay? So we're able to really produce a lot of force with isometric contractions. So we can use these in our sessions in kind of different ways. So we can use low intensity or submaximal intensity isometrics, and they can be really safe early on in the rehab program. No movement at the joint or the muscle. We're just asking it to contract, and that can really help to limit atrophy. But we can also perform high intensity isometrics, and we can produce a lot of force there with those. So we can use it for early phase rehab, we can use it mid phase, late phase. It just depends on how you are administering the isometric exercise. What's the intensity there? So maybe you're saying submaximal isometrics, 20% of your max effort. Or for something like when you're testing grip strength on a dynamometer, you're asking for 100% of that max effort. Same type of contraction, but they are very different in the way that we apply them clinically. Okay? And then the last one here generates the least amount of force, which a lot of people find, kind of surprising sometimes, is this concentric motion. So initially, concentric motions do produce a lot of force, kind of at the beginning of the range. So let's say for like a biceps curl, right? You're starting with your elbow in full extension. You go to contract your biceps brachii against that resistance. Initially, it's going to produce a lot of force. But as you work through that full arc of motion, the force output really decreases very, very significantly, very quickly. So for that reason, we label it here as number 3 on this list. And we're going to talk all about max, mod, and protection phases, different phases of rehab, and when it's most appropriate to start using those types of contractions. Okay, and then this is just a little bit of a refresher from the slide earlier about muscle fiber types, and gives you a little bit more information on resistance to fatigue. So again, we're going to talk about these energy systems, aerobic, anaerobic, fast twitch, slow twitch, all those things in our next chapter. So let's look at some signs and symptoms of muscle fatigue now. So at any point during the patient session, you start to see some of these things. You're going to want to not necessarily end the session, but give them a break, maybe move to a different muscle group, let that muscle recover, and then you can come back to reassess and see if they're still able to continue with the session. But again, really important to look for these kinds of things because your patients are all going to do these. So if they start to feel uncomfortable sensations in the muscle, pain especially, cramping especially, again, that's maybe a point in time where you're going to give them a break, move to a different muscle group. You may even just terminate that exercise for that group on that day. You also want to look for shaking, trembling of that contracting muscle. If they start to move more slowly during the contraction and you're trying to keep a constant velocity, that's signs of muscle fatigue. If they start to compensate or use substitute motions, so active movements, jerky, they're really inconsistent, again, another time to kind of just take a break. If they can't complete that movement pattern through the full range of available motion, then again, we're trying to limit injury here. We want to take another break. And if they're unable to continue low intensity physical activity, that's probably when we're going to call the session for that day, reassess on the next visit. So we want to make sure to look for all these signs of muscle fatigue as we're taking somebody through an exercise program. And of course, there are lots of factors that influence fatigue, including health status. Okay, what was this person like before they came into physical therapy or before their injury? Do they have any other comorbidities like diabetes, autoimmune disease? Those are all going to really heavily impact fatigue. Diet and lifestyle is another big one. Make sure that you're not judging your patients for certain things, but there's been some instances where I've had to discuss cigarette smoking, vaping with my patients because it really does influence fatigue quite a bit. And if their goal is to be more efficient with their cardiovascular health, then we're not going to tell them to stop. They can make those decisions. They're grown adults, but we can at least educate them on maybe why they're not progressing as fast. Medications is another big one. In semester 2, we talked about a lot of different medications, and a lot of the signs that you're going to be seeing and symptoms that your patients are going to be feeling include things like fatigue. So if they are on more than 4 medications, they're a big fall risk, which we'll talk about in chapter 8, I believe. But just be aware that medications can play a big factor for fatigue. So you want to structure it appropriately. And then, of course, any other environmental factors, hot days, if you're in a swimming pool that has lots of chlorine in it, all those things could really affect their fatigue levels. So, we're talking about fatigue. Let's talk about recovery from exercise. So as your patient is feeling all those signs or feeling all those symptoms that we mentioned earlier about muscle fatigue, that's when you'd want to, pause, let them recover, and it's important to know this time frame. So recovery from acute exercise takes up to 3 to 4 minutes essentially to return to 90 to 95% of that force producing capacity, but the greatest recovery occurs within that first minute. So again, if we're thinking of strength, power, and endurance, maybe if somebody's lifting really heavy loads and performing lots of powerful movements and activities, they might need this whole 3 to 4 minutes in order to recover. If they're working on endurance, well, maybe we give them the full minute because we know most of that recovery happens in that first minute. We can now move on to our second, third set, really stress that endurance and aerobic system out, and really build endurance for our patients. And of course, remember, fatigued muscles are more susceptible to acute strains, and you can kind of see this image here of Kevin Durant playing in the finals a few years back. He was dealing with calf strains for the greater part of the second half of the year, and eventually, because of fatigue, because of wear and tear, it's a long season, he ended up rupturing his Achilles tendon, and you can kind of see that pop right there and jiggle all the way up into that that legging there that he's wearing. So this is what we want to try to avoid with our patients, especially because they're coming to us after an injury. So we want to avoid re-injury, obviously, and any other form of new injuries. Okay, so some of the psychological and cognitive factors that affect exercise and muscle performance would just be your patient's attention, really getting in tune with their body. I always, really stress these kind of internal cues that your patients should be feeling. Sometimes people don't understand what it feels like to really exercise. They don't know what to expect. So you can tell them, about muscle burning, the pump sensation. A lot of patients, whenever I start exercising with them, I'm walking through a program, they feel that kind of uncomfortable feeling, and they say, oh, it feels like it's stretching. And that to me is really good feedback because I know that their muscle isn't stretching, but they don't understand what's really happening. So yeah, it's going to feel uncomfortable. You may feel that kind of burning sensation in your muscle. And again, that's a point in time where we would take a break and let them recover before we move on to something different. The other thing is motivation and good feedback from the PTA. So you really want to make sure that you show the patient improvements that they've made. That's why using objective measures like, let's just say a tug, for instance, or a wide balance test, grip strength, like that's why those are so important, right? Because maybe it's been 8 weeks, they still have pain, they're not back to their previous level of function, so they think that it's been a complete failure. And then here you come with all of this nice objective data that we've gathered over the last 8 weeks, and you say, well, no, we've actually improved quite a bit. This is where your strength was prior to starting your first session, your initial evaluation essentially, and here's where it's at now. Here are the things that you've improved upon, and here's some things that we still need to work towards. So sometimes when you lay it out like that for your patients, it gives them a new sense of motivation, okay? Because again, injuries, those kind of things, they can take a mental toll as well as a physical toll. Okay, and here's some of the physiological adaptations to resistance training. I'm going to kind of skip past these ones here, but you can read through those. Again, things that we all kind of know and we've talked a little bit about already. Some things that are really important whenever you start to really structure and assess your patients with these strengthening programs would be alignment and stabilization. And what I mean by alignment is something that you've been talking about in your kinesiology course, especially in manual muscle testing. In order to really get the correct muscle, or in order to target the correct muscle for exercise, we have to make sure of proper alignments. Like let's say for the glute med, for example, on this image here, right? We need to know the muscle orientation and the fiber orientation in order to put them in the best position to strengthen that muscle. Because if we flex the hip a little bit, right, we know that the TFL is going to take over for that movement in abduction now, because it performs hip flexion and abduction. Where glute med, it does a lot of different things, but its primary focus is really hip abduction, and especially on a stable, sound leg. Okay, so alignment is going to be really important, as well as gravity. So we have to consider that too with our MMT scores. And a lot of students struggle with this. They struggle reading an MMT score and then structuring a program based on those scores. So you just have to consider, right? What does a 3 out of 5 mean? It means that they can do full range of motion against gravity, but they can't really tolerate any resistance. So I'm treating this patient with glute med weakness. They're a 3 out of 5. Maybe I'm just going to do side-lying hip abduction, active range of motion, and that's going to overload the muscle well enough to strengthen it. But if I wanted to add some kind of resistance, like let's say a TheraBand or manual resistance, then I would have to change the effects of gravity. I would have to put them in a gravity eliminated position. So maybe supine with a band around their thighs, and then I ask them to do that abduction movement from that position. So again, the MMT score tells you what to do, right? It tells you what position to put your patient in. So really, really focus on that. These classes aren't so different, okay? We're just taking the data that we collect in one class, and then we apply it in this class, okay? As far as stabilization goes, this can, really make a big difference. And some of my best examples, I guess, would be if you are an avid gym goer. They have lots of grab bars. If you're doing something like a knee extension exercise, typically you're going to grab onto those bars if you're loading pretty heavily so that your bottom isn't coming up off the seat. You're stabilizing in order to really get the best power output. Okay, and then here are a lot of these determinants of exercise. So all of these things we're going to have to consider when we structure a program. And the big one that I would really kind of want you to focus on here is integration of exercise into functional activities. Functional, okay? Again, this is where a lot of students struggle. Even if they are avid gym goers, they'll think about things that they do at the gym and they try to apply that to a person who is recovering from a surgical intervention and they've had, let's say, a stroke previously. So now they're dealing with two things really. Remember that specificity of training, okay? Are leg extensions going to increase quad strength and help you get upstairs? Yeah, to a certain point they will. But unless you're doing stair training, you're probably not going to get better at that functional movement. So maybe it's just repetition in the movement itself that's going to make them better. Because I've seen patients with a 5 out of 5 score for their quads that really struggle getting upstairs. And you again would look at this and be like, well, they're really strong. They shouldn't be struggling with this. I'm kind of at a loss. What should I do? Well, make it functional, okay? Practice the things that are hard for them. That's the only way that they're going to get better, is practicing those things that are difficult for them. And of course, you always have to make sure that it's safe. So don't just progress them to stairs because the plan of care says that's their long-term goal. You have to make sure that they're safe in doing so first before you send them out and do those kinds of things. Okay, so we're not going to talk too much about this force-velocity relationship. We kind of hinted at it earlier when I was talking about concentric muscle contractions and eccentric muscle contractions, but we're not going to focus too much on this. We're going to kind of skip past this because we're not going to do any periodization of training. We're not creating cycles for our patients necessarily. But there are a lot of different types of resistance, and I want to kind of hint on this portion here. So a lot of times, students will grab a TheraBand, grab an ankle weight, and then that's it. And I mean, that's a lot of what we use in physical therapy anyways. Like, I get it, right? But, just remember that there's differences between these different types of resistances and when we would use them and when we wouldn't. So I might use manual resistance really early on in a rehab program because my hands on the patients, I know exactly how much force I can give them based on something like an MMT score. I can tell if they're overexerting and using too much muscle force in an injured site or a repaired site. So maybe I do all my isometrics manually, and maybe I do some eccentric training manually, and I can control the velocity of that movement. If you just tell your patient to go at it with free weights, with no instruction, they may be moving too fast. They may be doing all kinds of things that you're not wanting them to do. So manual resistance can be really, really good, okay? And the other thing that I really want you to think about with mechanical resistance is the difference, since we use TheraBand and those free weights so often, is the difference between those two. So when we're using TheraBand, as we stretch that TheraBand, it's going to provide more tension. So as you externally rotate your shoulder, as you extend your knee, that end range position of external rotation or knee extension, that's where we're going to have the most resistance, okay? So if somebody's really struggling at that end range and they can't get terminal knee extension, well, maybe it's better to use something like a free weight or an ankle weight, because that resistance isn't going to change through the arc of motion. And it is going to change when we're using resistance bands. So I really want you to think about that and maybe play with that in lab a little bit, because again, sometimes, we think free weight is the ultimate goal to get to, and that's great, and I agree, it'd be great to do that. But maybe they need a little bit more overload at end range, and that'd be more appropriate for a TheraBand. okay? It'd be appropriate if we're trying to use eccentric exercise, okay? Because we're starting with the most resistance at end range, and then we're slowly returning to that starting position. And as we return to that starting position, there's less resistance there now. So I really want you to think about the differences between ankle weights, free weights, cables for that matter, and then TheraBand, because it does matter which one you choose. Okay, and then as far as isometric exercise is concerned, we talked about this already here. So let's move down to this bottom bullet point. So when we're talking about muscle setting exercises, these are all different forms of isometrics, right? But for muscle setting exercise, this is where there's no added resistance. So I'm going to write QS here, okay? Because I want you to think of a quad set for this one, okay? So unlike your manual muscle testing position for the quadriceps where you're actually providing resistance, okay, don't let me break you out of this position. With a quad set, you're not adding any resistance. You're just asking the patient to contract that muscle. So like a quad set, a glute set. So it's still isometric, but there's no added resistance, not even gravity, okay? So they're just contracting the muscle. You put them in a position, you ask them to contract that muscle. Then we move on to stabilization exercises. So these are a lot of PNF techniques that you're going to cover in semester 4, but I'll write one up here. I'm going to write AI for alternating isometrics. Okay, so if we're trying to provide stability at the knee, the two major muscle groups that provide stability there, the two major ones, would be the quads and the hamstrings. So if I wanted to do something like stabilization exercise or alternating isometrics, I would just alternate between having the quads fire, having the hamstrings fire, having the quads fire, having the hamstrings fire again. So that's what alternating isometrics is. Great for stabilization. And the last one down here at the bottom, multiple angled isometrics. Basically what we're doing here is we're taking our patients through an arc of motion. So I'm going to write AOM for arc of motion. Okay? So they're not doing this whole arc of motion actively. So, and what I mean by arc of motion, like let's say we start sitting at the edge of the table with the patient's legs hanging off, so they're at 90 degrees of knee flexion. So multiple angled isometrics might start at that 90 degrees of flexion. We're going to do a 10-second hold here, push into my hand, good, relax, and then I move the patient into, let's say, 75 degrees of knee flexion. 10 seconds, push here, hold. Now I move it into 50 degrees, and then I work up to about 0 degrees. And then I can work back down through that range. So that's multiple angled isometrics. We're just taking them through an arc of motion, providing resistance. Could be high level, could be low level, depending on where your patient's at in their rehab phase. But we're not doing a full concentric movement. We're just kind of systematically moving up the chain, down the chain, utilizing isometric exercise. Okay, and something else that you have to consider for isometric exercise is a history of cardiac disease and vascular disorders. You're just trying to really avoid the Valsalva maneuver, which is where your patients hold their breath, and that creates a lot of internal pressure, intra-abdominal pressure, intracranial pressure, all those things. It could really spike their blood pressure, and that's not good for somebody that has cardiac or vascular disorders. So, not saying that you can't do isometrics at all for these patients with cardiac or vascular issues, but you want to make sure to tell them to breathe through this, make sure that they're not holding their breath. Those kind of things are something you look out for. Yeah. So now let's talk about these different forms of dynamic exercise, more so than isometrics, right, where we're just static. So why would we use concentric and eccentric exercise? Well, again, right, we're thinking a lot of our movements in daily life kind of involve both isometric and eccentric exercise, as well as a lot of isometrics. But when we're lifting objects, right, we're going to focus on concentric movements. And remember, this is the least amount of force produced. So we can use these kind of in like our middle phase where movement is allowed, but we're not trying to overload the tissues too much. Then we get into our minimum protection phase, and we're focusing on a lot of eccentric training, okay, decelerating the body, going downstairs, like those kind of things. We can really start to utilize those kind of towards the late phase of moderate protection, but definitely in the minimum protection phase. Okay. Some other things to consider for eccentric training is that if you are performing eccentric training for very specific, you're thinking specificity of training, you really want to do that at the velocity that you're trying to accomplish for your goal. So again, for somebody who is going back to sport, changing direction, that eccentric component happens very quickly, right? Slow eccentric loading of tissues for somebody who needs to stop on a dime, pivot, change direction is good. It's a start, but it's not specific to their training. So, and I mean, this goes for everything, right? Concentric, eccentric, whatever it is. But we really need to pay attention to the velocity of those movements. Okay, so a few more slides here, talking about open and closed kinetic chain exercises. So it is important to know the differences here because some clinical protocols, post-surgical protocols, will allow closed chain exercise and not open chain, kind of vice versa, or they'll ask for open chain exercise during a certain phase to really promote something like quad strength. So we need to know what open and closed chain really mean. And just a rule of thumb, if you're focusing on one specific joint movement, okay, something like knee extension from seated, that's typically going to be open chain activities, right? Whereas closed chain activities typically will emphasize something like joint compression, and you're thinking that you're using more than a single joint, like let's say a squat. So in both our scenarios, we're trying to strengthen the quads, right? Open chain knee extension, where only the knee is moving. And then we have something like squat, closed chain, which is where we get joint compression through axial loading, but we're also getting hip flexion, we're getting knee flexion with that, we're getting ankle dorsiflexion, so it's really focused at a lot more than just the single joint. So here are your two examples. And of course, there's tons of other characteristics and terminology that I did not list. You can check table 6.7 for some of those terminology characteristics. And then there is table 6.8 that gives you a reference for open and closed chain exercise. Okay, so implementing resistance exercise, we're going to talk about all of these in lab, but we are going to really follow these pretty strictly for our skills competencies, lab practicals, those kind of things. So we'll talk about these again. Again, some other things that we've talked about already. And we're going to kind of skip past these last ones here. As far as contraindications go, should be aware of these ones here. So are patients going to be in pain coming into physical therapy? Yes, but resistance exercise should not increase their pain. That's what we're looking at. If there's tissue inflammation, right, we're going to think about not performing any of this resistance exercise, especially if they have an inflammatory neuromuscular disease, something like Duchenne's, where actually performing high-level activities, a lot of strength, a lot of power training, just overworking the muscle in general, even with endurance, could actually cause more of those symptoms, can worsen their condition. And then, of course, again, thinking about severe cardiopulmonary disease, what are the effects of exercise on the cardiovascular system? We have to know those and just pay attention to that. Okay, we're going to kind of skip past these things here. We're going to star this slide for semester 4, but not for our class this semester. Same with this one. And then there is a little bit in your book about blood flow restriction training. You can take a peek at that. It's nothing that we're going to quiz you on or anything along those lines, but really cool area of physical therapy. They're doing tons of research on it, so maybe we'll come back to this. And that's it. So I hope this is helpful for you. If you have questions, feel free to reach out to me with anything that you may have. We'll see you on the next one.